middle of the night for them. So we'll record the session so we can share it after. Now, this session should take no more than about 45 minutes to sort of 50 minutes altogether, and then we'll have a second session on Thursday. So the purpose of the call today and Thursday is to get you prepared for your entrance exam. So when we bring you all together as a group, we'll do an entrance exam on anatomy because we want to make sure that everybody's at the same level if possible. So that can help us to then go through the training, because in a week, you know, we're cramming in a lot of information in a 1 week period. And so coming in and being quite strong in anatomy is really important. So that's why we're offering these calls for everybody. So hopefully you can stay for the full call today. And what we're going to do is you can put your camera on at any time. You can come off mute if you want to ask a question. The slides that I'm sharing with you are already slides that will be available to you on anatomy. I'll share the whole presentation after Thursday, so you can use it for revision. And the other thing is, as I go through the presentation, because we want to make this a little bit interactive today, then we will, I'll be asking you some questions every so many slides, doing a little knowledge check. What I'd like you to do is put your answer in the chat. So there'll be some little knowledge checks, multiple choice, A, B, C, D answers. And then I want you to put it in chat and see if you're managing to get these things correct, okay? It's important that you just feel comfortable with your anatomy for day one on the training. So spend some time on that over the next couple of weeks before we come together in Dubai, okay? So I'm going to pull up my presentation. What you'll notice on the presentation is I've added subtitles in Russian for our colleagues on the call that speak mainly Russian as their main language. And so you'll see some Russian subtitles coming along the bottom of the actual slides. Now, hopefully it will be reasonably accurate. I don't see Olga or Yelena's here now, so that's good. I want to ask Yelena a question. Yelena, I'm adding the subtitles. Are you here now? Can you hear me? Yeah.
Everyone, yes, I'm here now. Thank you so much, Maria.
Yeah, thank you, my dear. So I've added the subtitles. They'll show along the bottom of the slides. Hopefully they're very accurate, and hopefully that will be a help to our colleagues from the Russian team, okay? Yelena, as Christian isn't joining the call today, maybe you can just keep a little eye on the chat, and if somebody's trying to ask a question and I'm a little bit distracted, then maybe you can just raise your hand or come off mute and just let me know, and we can deal with the questions as we go. Okay?
Sure.
So just 1 second. All right, so I'm going to share my screen. So just let me know, Yelena, you can see the screen in its proper view, not presenter view.
Yes, I can see the presenter view.
You can see my view, yeah, not the, you can't, you're not seeing the notes and things. No?
No, no.
Okay, that's good. All right, okay. So now you'll see the subtitles are coming up on the bottom. Hopefully that will be useful for our Russian colleagues today. And we'll just carry on with the presentation. So this will be the first half of this presentation today, and we'll do the other half on Thursday. So when we start to think about the brain in general, we also have to just start thinking about arteries and veins in the body. So when we look at blood flow sequence, here you can see we have an arteriole and we have a venule, and we have a network of capillaries that help to join these together. When we think about the arteries, blood is carried away from the heart through 5 types of blood vessels: arteries, arterioles, capillaries, venules, and veins. We know that arteries have high pressure. That's why we're concerned when we have a rupture in the brain. We know that arteries have quite elastic walls. So they expand when a surge of blood enters from a contraction in the heart. They relax to normal size when the rush of blood pauses and the ventricles fill before the next beat. This is important to remember that the aorta, which if I can just get my little pointer, we know that the aorta, so you can see I'm pointing here, actually maybe red's not the best color, excuse me. The aorta here is the largest artery in the body. So when we start to think about even how do we get to the brain, and we think about the femoral artery down in the groin, then usually that's the main point of access, and we're going to go from the femoral artery and we're going to then go all the way up through the aorta, across the aortic arch, and then up into the neck. But it's important to know that the aorta is the largest artery. It leads away from the heart into smaller arteries, and the smaller arteries carry blood to even smaller structures called arterioles. Arterioles then merge into a microscopic network of capillaries. When we think about capillaries, they're so small that they can only be seen through a microscope. They connect the arteries to the vein and allow the body to absorb nutrients, such as oxygen, carried in the bloodstream. Here you can see how the capillary network is connecting arteries and veins. When we think about veins, we know that veins carry blood back to the heart. They're much less elastic than arteries, and the pressure in the veins is much less compared with arteries. They have valves that allow the blood to flow only toward the heart, preventing backflow. And the largest vein in the body is the vena cava. The vena cava's superior and inferior branches enter the right atrium of the heart, and cerebral veins drain into the duro-venous sinus. When we start to think about blood vessels, they have 3 layers. This becomes important when we think about deploying devices inside of a vessel. We need to know the layers because we need to work out where the damage can occur through both rupture of aneurysms, dissections, and then also damage that can be done with our devices. So we have the tunica intima, we have the tunica media, and we have the tunica externa. So these make up the layers of the blood vessels, and all of these layers can be affected by aneurysms, and all of these layers can be damaged by dissection or device deployment. So when we think about the difference between arteries and veins, arteries are thicker than veins because the middle layer, the tunica media, is composed of muscle. The muscle provides the strength that arteries need to withstand the constant pressure exerted as blood is pumped from the heart against gravity. The arteries are directly filled by the power of the pumping heart, and veins are not as strong as arteries because the muscular layer is poorly developed and not as thick as we see it in arteries. To prevent the blood from flowing the wrong direction and to keep it going toward the heart, a system of valves is required in most veins. Now, this is us starting to come on to a really important diagram. And when it comes to your understanding of how do we access the vessels in the brain, this diagram, you need to know this diagram inside out and back to front. You really need to understand the relationship from coming off the arch and then going into the vessels that will take us up into the neck, front and back, to actually reach those vessels that form part of the circle of Willis. Okay, so 2 things we talk about are anterior circulation, and these the anterior circulation is via the carotid arteries in the front of the neck, and the posterior circulation is reached via the vertebral arteries in the back of the neck. Now, this is really important for both hemorrhagic stroke and for acute ischemic stroke. Okay. Then when we think about these circulations, so how blood is circulated, when we take the anterior and the posterior arterial circulation, they connect and form something called the circle of Willis. And this is really important to us in our organization because this is where aneurysms of the brain occur. Okay, so you're going to see some drawings like what we see here. I'm sorry, I'm just going to get my little pen again. You're going to see these kind of animated drawings of the aortic arch and the vessels that come off it. You're also going to see some angiograms as well. And this is what we need you to learn, okay? So we need you to start thinking about the aortic arch. We need to start thinking about whether the vessel is on the left side or the right side. And when we talk about that, we mean the left or the right side of the patient. Okay, so it's not your left or right. So you have to get your head around thinking about this. So when we look at the patient straight on, and when we talk about imaging, normally we're looking at an AP view that can determine whether we're on the left or the right side. So here you can see coming up on the patient's left side, we see the arch, we see the left subclavian, we even see the left internal mammary artery, which is becoming more of interest. We then see the left common carotid, we see the left internal and the left external here on the patient's left, okay? On the patient's right, when we actually come from the arch, we come into a different vessel from the left side. This is known as the brachiocephalic, but it has a second name, and they both mean the same thing. So the second name is the innominate. So you need to learn both of those names, okay? Then it becomes the right subclavian. There you can see the right internal mammary again. Then you can see the right common carotid, the right vertebral, the right internal and the right external. And you can even see here, coming up from the vertebral, it's starting to show you the basilar in the back of the head. So quick knowledge check. So I wanted you to put this into chat, and if Yelena can have a look at the answers in chat and just read out what people are saying, Yelena, because I can't see the chat at the moment. So what is the largest artery in the brain? Is it A, the iliac artery, B, the aorta artery, C, the brachial artery, or D, the internal carotid artery? So put your answers in chat, A, B, C, or D. And Yelena, if you don't mind just reading out some of the answers that are coming up in chat.
Sure.
What's the predominant answer? A, B, C, or D?
No answers.
Come on, don't be shy. You're going to be asked these questions a lot, so this is your chance, yeah? Just make a guess, okay? You may be right. So we've just covered it, we just mentioned it. So what is the largest artery? Sorry, not in the brain. Sorry, the question is wrong. This is my fault. What is the largest artery in the body? That's probably why there's no answers. See, I got this wrong already. What's the largest artery in the body, not in the brain? This should be easier. That's my bad. What is the largest artery in the body? Now are we seeing some answers, Yelena?
No, there is silence.
There's a lot of silence. Why don't you type in your answer and see if that encourages people to give an answer?
Sorry, ladies, I see in the chat. There is in the chat a lot of answers B and D. Before
Why I
was
don't
D
see
and
it?
after body B.
But
Oh,
why
thank you, Olga. So there's lots of answers B and D, and that's because that's because I've written the question wrong. So that's my bad. So so just for everybody again, the largest artery in the body, not in the brain.
That's strange. I don't see any answer. So probably there is
Olga,
something bad
Olga
with
needs
my
to read
team.
out the chat. Okay, so
Okay.
largest artery in the body, not in the brain, is the aorta. Yeah, remember the aorta comes up behind your abdomen and then actually joins and becomes the aortic arch. Okay, so first question out of the way. So as we talked about, we start to then we've come up across the aortic arch. We've got the right and left subclavian, we've got the right and left subclavian, we've got the right brachiocephalic. We're either coming in up in the front through the carotid arteries, and this is what you're seeing here, okay? So what you're seeing in the neck, and this is normally, again, a point where we can check pulses, okay, which is quite common. So the common carotid artery, as you can see here, yeah, is all the way up in the neck, okay? And then it bifurcates just below where you would think about your head and your face and your chin, and it becomes the internal carotid artery and the external carotid artery, okay? You'll soon see some angio images that shows you this in more detail, but just so that you know, the internal carotid artery at the very proximal end, so as we enter into the ICA, it doesn't show any branches really, and that's how you can usually determine which is internal and which is external. So now you see a sliced view of the brain, and you can start to see again. So here in the front of the head, you can see coming up from the common carotid, we have our internal carotid artery, okay? And then in the back, coming up from the vertebral, we then have our basilar artery, which then joins to the PCA. If we come all the way up the ICA, we'll see 3 branches that come off the ICA. We'll talk about them in more detail in a minute. And then eventually when the ICA bifurcates, it becomes the anterior cerebral and the mid-cerebral artery, okay? Next slide. How do we start to think about, determining what disease state is occurring, okay? So patient has some kind of incident. We are trying to determine whether this person is having many different types of things that could be happening, especially if they present with like a road traffic accident or something else, some other kind of symptoms. So one of the most common piece of kit that we see used today is a CT scanner. So most hospitals now, even smaller, what we call spoke hospitals, should have a CT scanner. And so CT stands for computed tomography. It's very fast and very widely available. CT scans are often the first imaging modality used in acute stroke situations. And that can be both hemorrhagic or acute ischemic stroke, okay? The CT angiography can visualize the vascular system, helping to identify blockages or other vascular anomalies. MRI is also another mode of imaging that's used, again, it's widely used today compared with even 5 or 10 years ago. A lot of centres also now have an MRI scanner. So this stands for magnetic resonance imaging. This would offer a really detailed image of the brain's soft tissues. It's very useful in planning interventions and assessing their outcomes. And it's particularly valuable for visualizing the brain structures and any ischemic or hemorrhagic damage, okay? Now, when we come together in the training, we'll go into imaging in a lot more detail around what would be the most normal imaging on a patient pathway presenting with hemorrhagic stroke compared with a patient presenting with acute ischemic stroke. Then we take it one step further and we do what we call a CT angiography, or CTA for short, or an MR angiography, so MRA for short. So the purpose then is to provide detailed images of blood vessels, identifying any occlusions or stenosis, or other disease state like aneurysms. So the application is that it's critical for planning interventional treatments by mapping the vascular anatomy. So as you can see here, we're starting to look at the vessels that are part of the circle of Willis. Here we're looking at the anterior circulation, and here we're looking specifically at the ICA, and then when it bifurcates into MCA and the ACA, okay? We then go a step further again during a procedure, and we do something called digital subtraction angiography, or DSA for short. I'm sure most of you are very familiar with this. So what is DSA? It's a gold standard in vascular imaging. So the point of doing DSA is that it provides clear and detailed images of blood vessels in the brain, but it subtracts the bone and the soft tissue images from around the blood vessels, so that all you see are the blood vessels, and these are the blood vessels filling with contrast material. Yeah, it's so important for being able to diagnose vascular conditions, and to see if there's any stenosis, to see if there's any occlusions from an acute ischemic stroke, to see if there's any aneurysms or AVMs. So here we start to see some images. If you're quite new to neurovascular, sometimes you'll look at these images and immediately you just think, what am I looking at? Okay, so we will go through these images in a lot of detail over the course of today and Thursday, and then also when we come together in the class as well. Okay, so normally when you see an image like this, what you're trying to determine is what kind of view is it. So in neurovascular, we use something called biplane, which we'll talk about more when we're together. What that means is there's two different types of images that are available on a screen at the same time. Okay, in general peripheral intervention, where they're looking at the arteries and the veins all the way up to the neck and all the way down to the feet, they can use single plane angiography because the vessels are much bigger, and they're able to determine and see any disease state and manage it using a single plane setup. In neurovascular, as you can imagine, we're dealing with tiny little vessels that are like 1 millimeter, 2 millimeters or smaller. Okay, so we need to use two different planes, which are AP, as we call it, which is anterior posterior, where we look from the front of the face to the back of the head. And then we have lateral, which is the other part of the machine that comes in and looks at the head from the right and the left side. So when we start to look at these images together, we will be determining, is this an AP view or is it a lateral view? That would be the first question, okay? When you look at an AP view, which is what we're looking at right now, then it means that you can determine whether you're looking at the right or the left side, okay? So on this image here, what I always say when you're thinking about an image, start with the largest vessel to try and work out what it is, and then from the largest vessel, yeah, that you can then determine where we're starting from. And when you start to look at the largest vessel, then you start to work out in your understanding. So when that vessel eventually bifurcates, which means it breaks and splits into two new vessels, then what are those vessels? And then you have to think about, I can see the other side of the image as well. So I'm seeing a little bit of a patient's right and left side, okay? When you see an image like this, which would be patient's right side, this is where the injection has gone. So the injection has gone into the ICA on the right side of the patient, because here you're not seeing that left ICA, okay? So you're not seeing that left internal carotid. So the right-handed injection means you're seeing all of this right side of the patient, but because of the contrast and the anterior communicating artery, the contrast is also flowed into the other side, so you get to see the other side as well. Okay? So going back to what I said before when we had the animated aortic arch, okay, here you're seeing the angiogram. So as we start to prepare for a procedure or just to do what we would call a diagnostic angiogram, we need to be able to access, again, this would be a femoral access. So we need to be able to access in the femoral artery and then make our way up with guide wires and diagnostic catheters and short, long sheaths. We start to navigate our way up. And as we go, using the diagnostic catheters that have holes in them, they're injecting contrast as we essentially go from the femoral artery up to where now we're seeing the aortic arch, and then up into those vessels that take us up into the neck, and then up into the brain. So this image is something that you really need to know and understand. It's critical for your exam, and it's critical for your understanding of how do we get from the femoral artery up to the arch, and then now how do we navigate over the arch and into the correct vessels depending on where we think the disease state is. Okay, so starting from proximal here, when we look at this first image here, you can see it's telling us the answer. This is the aortic arch. Okay, number 2, This is the left subclavian. So again, it's the left of the patient. Number 3, this is coming up into the left common carotid artery. And then number 4, which is coming here off the subclavian, this is your left vertebral artery. And then if we come over to the opposite side, what you can see here, if we just start with 7, because this is coming directly off the arch on the patient's right side, we actually have the brachiocephalic or the innominate artery, and then it becomes the subclavian, okay, as it goes up and over the shoulders, which is where your subclavian arteries are. The right common carotid is seen here coming off just when the brachiocephalic becomes subclavian, and then again behind, which would be really in the back of the neck, you can see the right vertebral artery. Okay, so this is something that you need to know inside out and back to front. Okay, without knowing that, you're not going to be able to get up and into the brain. And the only other thing I'll mention here, which we'll talk a little bit more when we're together in Dubai, not all patients have a straightforward aortic arch. There are different types of aortic arch. So how the vessels leave the aortic arch can have different configurations. Okay, this is a straightforward arch here, but we'll talk about the different types of arches, but not today. Okay, so knowledge check again. Olga, if you can help me out here, if you're seeing what's in chat, if everybody can write down the name of number 1. So I've just shown you it. Tell me what this is here. What is number 1 referring to? So Olga, are you seeing any answers in the chat?
Aortic arch.
Yep, aortic arch. Good. Whoever got that correct, well done. Number 2, this vessel here. And you need to say whether it's right or left. This vessel here, number 2.
So the first was left subclavian.
Left subclavian. Are you seeing that in the chat? Are people getting that one correct? Yeah? Okay, left subclavian artery.
Left subclavian.
Okay, good. Number 3, this vessel here. Right or left? Which vessel is number 3?
No answers yet.
No answers? Number 3.
Vertebral artery. Left common carotid.
Okay, so if we think about
Left vertebral, left common carotid.
Yeah, so obviously
2.
people are still learning, but this is the left common carotid, okay? It's coming directly from the arch, as you can see here. And this is a bigger vessel. If we think about the size of vessels, and some of you got it right in that first question, when we think about the largest, vein arteries in the brain. So here we're coming up into the neck, and the left common carotid is bigger than number 4. The diameter of the left common carotid will be wider than number 4, which is
left
answers in the chat. The left vertebral, yeah. So you can see here it's coming from the subclavian. So that's in the back of the head, okay. And it's usually, when you look at an image, normally the vertebral artery will be smaller in diameter than the common carotid, okay. So number 5 coming over here on this side. What vessel is this?
No answers yet. Right carotid, common carotid artery.
Yeah. The good thing about a lot of these vessels that we see, we always see a right and a left, okay? So if number 3 was the left common carotid, number 5 is the right common carotid, going up on the neck on the right side, okay? So if that's the right common carotid, what is number 6? See, it's coming here from where the brachiocephalic turns into subclavian. Number 6.
Right vertebral.
The right vertebral, okay?
Right
so
vertebral.
Right and left, okay. And then if we come back down to number 7, so this is coming directly from the arch. What is this vessel known as?
Brachiocephalic.
Yeah, it's the brachiocephalic, or the other name for that is the innominate. Okay. Now,
Mhm.
well done, everybody. Before I go to the next slide, I just want to mention something. Sometimes when we're looking at images as well, when we're new, we kind of really kind of hone in our view, and we're looking and we're trying to determine. Sometimes when you see a view like this, it's better to try and open up your mind to the whole image, because that can help you determine whether we're on the right or the left side. You can see here on this image, it's actually got right. So that helps you to determine what is the right side and what is the left side. So always just open up your mind a little bit when you're looking at these images, and it'll help you to see the whole picture. Okay? Another knowledge check. So the common carotid artery bifurcates and then it becomes two new vessels. What are the two new vessels when the common carotid artery in the neck bifurcates? Is it the internal carotid artery and the external carotid? Or is it the anterior cerebral artery and the mid-cerebral artery? Or C, the brachial artery and the subclavian artery? Or D, the internal carotid artery and superior carotid artery? Which is the correct answer? Any answers in chat, Olga?
Yes, there is answers like A.
Yeah, A, B, C, or D? Yeah?
A. Most of
Lots
the
of
answers
A's.
A.
Yeah, all right, cool, perfect.
Mhm.
That's what I wanted to see. So well done, everybody. So the common carotid artery, when it bifurcates, normally when an artery bifurcates, it becomes a new artery. So when it bifurcates, it becomes the internal carotid and the external carotid. And we are mainly interested in the internal carotid. So here you can see a picture of exactly what happens where when the common carotid artery bifurcates and becomes those two new vessels. And here we can see the common carotid arteries here. Here we can see the external carotid artery, and how you can determine it when you look at this image is on that proximal end. So you know proximal is the lowest part before we go distal. On this image, you'll always see lots of external branches coming from the external carotid, whereas when you look at the internal carotid, it doesn't have any branches down on the proximal end, okay? Or not any significant branches that we can see, okay? And here is what we call the carotid bulb, which helps to control a blood pressure. The thing about the carotid bulb is sometimes when you see it, you have an idea that you think you're looking at an aneurysm because it's bulging, but that's just the shape of the carotid bulb, okay? Quick question for a bonus question, anybody put it in chat. If we're coming from the femoral artery in the groin and we're coming all the way up through the aorta, up and over the arch, we're coming up into the common carotid artery, and then we're starting to think about going into the internal carotid. If we were going there with a long sheath, if we were taking a sheath all the way from the groin and up into the internal carotid artery, where would the sheath go? At what point on the internal carotid would we have a long sheath? Any suggestions? Thinking about a long sheath, if you know anything about long sheaths, what's the length of a long sheath? What's the average length? Where do we take that to then give us a good anchor for then delivering our intermediate catheters and our microcatheters and then eventually our devices? Where do we think we take a long sheath? Any answers, Olga?
So
in
there
the
is
chat?
answers here. I see Petrov's segment.
Okay, so that's a good answer. So we're going to be talking about the segments of the ICA, but essentially most long sheaths, the average length is about 90 centimeters. So that would normally sit a little bit lower down in what we call the cervical segment, okay? But whoever answered that, you're also correct, because long sheaths can also be longer than 90 centimeters. So they could end up coming up into petrous, okay? But mostly if we have a long sheath in our access setup, sits around the cervical segment. Then when we think about intermediate catheters, they would go a little bit higher, okay? But good answer anyway. So when we start thinking about then our two different circulations, we mentioned that we have an anterior circulation and we have a posterior, okay? So the anterior circulation arises from the internal carotid arteries and includes the anterior cerebral artery and the mid-cerebral artery, okay? And the anterior circulation provides blood to most of the cerebral cortex. When we think about then our ICA segmentation, I wanted to mention the classification that we tend to use today. Now, in your countries, you may still use some other types of classification, but the most common one that we use worldwide is the classification of Boutillier. So these are doctors who normally then would come up with their classification and then they publish, and then I'm going to show you some images of what that looks like. So this was a modified Fisher classification back in '96, and the idea was that we took the ICA and we decided on the segments in the direction of blood flow. So when we think about blood flow in the ICA, yeah, it's coming up from the aortic arch up into those vessels in the neck, and then it's continuing to travel distal, if that makes sense. So whenever we talk about the ICA segmentations, I always want you to remember to talk about them from the most proximal segment to the most distal. So always in the direction of blood flow, okay? So here you can see a nice image of what the Boutillier classification is. And here what you can see is the first segment. So this is how I want you to remember it, always from proximal, okay? So first segment is the cervical segment. The second segment is what we call the petrous segment. Third segment is a little short segment known as the lacerum segment. Then we have the cavernous segment. You can see here, as it said, it was alpha numerical. So we talk about C1, C2, C3, C4, C5, C6, and C7. And then they have the names, okay? So the segments are named. So cervical, petrous, lacerum. Then we come up to this cavernous segment. Then we come up to the clinoid segment. And then C6 is the ophthalmic segment. And then finally, just above the ophthalmic segment, we have what we call the communicating segment. Now that makes a lot of sense, because then when the ICA finally bifurcates, yeah, it means that that segment of the ICA is communicating with those new vessels, okay, which are your ACA and your MCA. So really important for you to know this inside out and back to front. Whenever I say that, it really means you do need to know it, because you'll be asked this time and again. And when I asked the question a minute ago about the long sheath, the reason I asked is that some of you may already be selling access products from other companies. With our company, we are now starting to bring access products for you, okay? So you'll be learning about access products when we come together. So we want you to understand the relationship between any kind of setup, whether it's coaxial or triaxial. We want you to understand, what does that mean? And where would those devices go? At which point of the ICA would we take those devices, and why? Okay, so when we talk about long sheaths, they come up and sit here in the cervical segment. Then we would then take an intermediate catheter or a DAC, which normally is going to sit in and around the petrous segment, or a bit closer to where the disease state is. And then inside of the intermediate catheter, we'll then have a microcatheter. We always need a microcatheter to deliver whichever device we take there, okay? Whether we're going to deliver coils, we need a microcatheter. If we're going to deliver a flow diverter, we need a microcatheter. If we're going to deliver a stent, we need a microcatheter. If we're going to deliver an acute ischemic stroke thrombectomy device, we need a microcatheter, okay? And the microcatheter is the device that will go as close to the disease state as possible, okay? So just a little bit of thinking. I want you to think about why I'm asking you that, okay? And then, like all the imaging that I'm showing you already, even if you just look here, Normally, we would start with the longest vessel, the biggest diameter vessel, work out where we are, what we're seeing. Then it helps us to work out, okay, so if this is the internal carotid, what happens up here? Do I have some branches that I need to learn about? Yes, we do. Then when it bifurcates, what are these new vessels? And then we think about all vessels have segments, and we'll learn all of that together. Okay? So, oh, I think somebody's maybe coming in again. This is just another little animated version. So here, if we think we're coming up here from the common carotid, this would be our external carotid. This is our internal carotid. And here again, you're starting to see those segments: cervical, petrous, lacerum, cavernous, clinoid, ophthalmic segment, communicating segment. And here I wanted to point out three important vessels that you need to know, okay? So when we're coming up the ICA, we will have smaller branches that we're not seeing that are so prominent. But the three branches I really need you to know. Now, this is an artery that comes off of the ICA, and this is before it bifurcates, okay? So here at the top of this drawing, this is where the ICA is bifurcating and becoming new vessels, okay? But there are three arteries that branch directly from the ICA, and it's important for you to know what they are. So the first one is the ophthalmic. So as we go from proximal to distal ICA, I want you to remember the first branch that comes off the ICA is the ophthalmic artery. Okay, then as we continue into this ophthalmic segment, the second branch is the posterior communicating artery. Okay, and then the third branch is the anterior choroidal. Now it's not written on here, but you need to remember those three vessels. So these are important when we are dealing with aneurysms in and around this location, which is a really common location for aneurysms, okay? So first branch ophthalmic, second branch posterior communicating, third branch anterior choroidal. Okay, so we won't be asking you anything about any other smaller branches at any other point of the ICA apart from these three branches. And then eventually it bifurcates, and as it says here, it then becomes the anterior cerebral artery and the mid-cerebral artery after the bifurcation. Okay? A couple of extra little drawings. Oh, actually, no, I'm going to go back because there was something else I wanted to mention here. So some of you may hear your customers referring as C6 as being the hypophyseal segment. Okay? But what that really means is the segment, according to Boutillier, is known as the ophthalmic segment, okay? However, the most distal part of the ophthalmic segment is known as the hypophyseal segment. So this is where the word hypophyseal comes from. So, you know, we're teaching you everything kind of word by word. When your customers are speaking about it, if they refer to, oh, the aneurysm is in the hypophyseal segment, okay? What they're telling you is that within this full ophthalmic segment, in and around the ophthalmic artery, that the most distal part of the segment is known as the hypophyseal segment. So it means that the aneurysm is higher up and more in this hypophyseal segment than it is further down in the ophthalmic segment, okay? So just if you're hearing the terminology, then that's what it means, okay? So there's a couple of other little drawings here. One thing I want to mention is we talk about, you know, intracranial aneurysms or extracranial aneurysms. That's important because it's inside of the skull base. So we want you to think about those intra and extra cranial aneurysms, okay? And then we'll also talk a little bit about intradural and extradural. We'll cover that in more detail. You don't need to know that today when we come together. There's another little diagram I just wanted to show you because quite often we talk about where are the most common places for aneurysms to occur, okay? And even though we see a lot of aneurysms in this ophthalmic segment, as you can see here, and they all have different types, okay? what I want you to remember, and I think we go through this in this presentation anyway, the most common places that we see aneurysms are what we call PCOM aneurysms. So that's actually an aneurysm that's within the ICA, but it's as we go into the bifurcation of the PCOM artery, it's a really common place for an aneurysm. And that's the thing about aneurysms, is anywhere where a vessel bifurcates is a weakened point, and that's why aneurysms can occur there. So PCOM is one of the most common locations, and also ACOM. So that anterior communicating artery taking the right and left ACAs is another common place for aneurysms. And then third on the list is MCA, but usually between the M1 and M2 bifurcation. So when we talk about segments, we'll cover that together. And then the fourth most common place after that is basilar in the posterior circulation. Okay, so we will teach you all the percentages, but I want you to remember most common places for aneurysms is PCOM, ACOM, MCA at the M1, M2 bifurcation, and basilar tip. That's just something to think about overall, and the way that these percentages are worked out will all be slightly different in the literature. So when we say to you PCOM and ACOM are 30 to 35% of all aneurysms, don't get hung up too much on some publication telling you that it's more like 30 than it's more like 35, okay? For the purpose of learning, we'll teach you those percentages and we want you to remember them. But what was important about this that I wanted to just show you was quite often in this segment here, so in this ophthalmic segment, yeah, we see a lot of aneurysms. And so they can be described as different things. So any aneurysm in this segment here, your customer may see this is an ICA aneurysm, or your customer may see this is an ophthalmic aneurysm, or they may see it's an ICA aneurysm at the origin of the ophthalmic artery. And so you'll hear these different descriptions, so don't get too concerned about that. It's nice to talk to your physicians and ask them, why do you describe it like that? If it was an aneurysm that's, say, up here, and it's at the origin of the PCOM, why do they refer to it as an ICA? That's just the way that they refer to it, okay? But here at the origin of the PCOM artery, this is where we see a lot of aneurysms. And then here you're seeing some more angio images. Here we're seeing a DSA image showing an aneurysm. And again, it describes it as originated from the right ophthalmic segment of the ICA. You can see that the aneurysm was treated during the procedure and the lesion was completely embolized in the immediate angiographic result, okay? So here you're seeing the steps of coiling and you can see now the finished image here down at E. So this is the kind of images that we'll be taking you through, both during these sessions and also when we come together in class. And we just really want you to become very comfortable, okay? So any image like that, always start with the largest vessel, work out where you are. Think to yourself, is this anterior circulation or is it posterior circulation? So then you eliminate other vessels, okay? So you can say, okay, this is anterior circulation. And then you can tell yourself, well, what is the major vessel that's coming up from the neck in the front of the patient's head that then leads up to these other vessels? Then you tell yourself, okay, this must be the internal carotid artery. And then as you're looking at it, you're working out what branches can I see, depending on whether it's an AP or a lateral view. What disease state can I see? Well, this looks a bit suspicious. And then we think, what else do we see? So we think about the ICA. We know when it bifurcates, it becomes two new vessels, which are the anterior cerebral and the mid-cerebral. Then we start to work out, well, how do we know which is which? And again, we'll go through more details about understanding distribution of blood. What do these vessels, where do they supply blood to? That will help you to look at an image and determine which is ACA, which is MCA, and then you can then work out segments, okay? So the carotid cave, this is where the carotid artery enters the dura mater. An aneurysm here is considered intracranial and commonly known as the carotid cave aneurysm. However, it can be entirely extradural as well. And when you read any of the papers in the literature, it will tell you if it is slightly extradural to the cave, then it would be considered an extradural. And it would have some other factors to consider. This is just a little picture actually showing you the carotid artery as it enters the cranial vault. And then here we can see the distribution of blood for both the anterior and the mid-cerebral artery distribution. So if we're thinking about the brain, you can see here that anterior cerebral is kind of going all the way up to the top of the brain, okay? So when you start to think about images and you're looking at an AP view of an image or even a lateral, and you're seeing these arteries being distributed up in this direction, then you can be almost sure that you're looking at the anterior cerebral artery. And then the mid-cerebral artery, again on a nice AP view, you start to see that vessel supplying blood and the contrast run going out towards the side of the head. Okay, so that'll all help you to start thinking about what you're looking at. So, final knowledge check today. What are the 7 segments of the ICA? And that's from the proximal ICA to the distal ICA. So what do you think is the correct answer? A, B, C, or D?
No answers yet? Okay. The answers is coming D. D, D.
Yeah, D, 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 D.
Only to D yet?
That's good. That's what I wanted.
Now it's a lot D.
All D. So we're all
Yeah.
very clear, yeah? So from proximal ICA to distal, we start with cervical, petrous, lacerum, cavernous, clinoid, ophthalmic, and communicating. That's the correct answer. So I'm just going to come out of that presentation. Oh, I'm just going to stop sharing. So I just wanted to take us that far today, just to make very clear what I need you to know and what I would like you to know. For those of you that are very experienced on anatomy, I know that you probably already know that, but I just want you to think about all of those factors, okay? A lot of the things I was being very clear on are things that will be in your entrance exam. So please, when I share this presentation after Thursday, you can just study it again, make sure that you're very comfortable, test yourself, and also continue to complete the online work, okay? So any questions about the session today? Anything that you wanted to ask around anatomy? Anything that's unclear? Yeah, so I can see that there was a couple of comments in the chat around long sheaths, okay? So the most common length of a long sheath is 90 centimeters, which then goes into sort of ICA segment in the cervical segment, yeah? If they take a longer sheath, depending on the patient, depending on where the disease state are, then there's usually a couple of extra lengths of sheath. Elizaveta, you said 80 centimeters. You're correct. There is also a slightly shorter long sheath that would be 80 centimeter. That would absolutely only reach just above the carotid bulb. Okay, so as you're thinking about your access, that's really important. Okay, so most average length, if you get asked that question of a long sheath, is 90 centimeters, but they can be slightly shorter at 80 or slightly longer at 100 or 115. And then when we start thinking about then intermediate catheters, we then think, well, if we're going to put an intermediate catheter inside of a long sheath, including attaching it through an RHV, what does that mean? So then we start to think what lengths of intermediate catheters we need. Otherwise, if it doesn't come out of the other end, how can we then have any more stability and any more extra length getting towards the disease state? Yeah. And then microcatheters even longer again. So I hope you enjoyed that session. I hope that everybody's starting to understand what the expectations are. Any final questions? From anybody? Was that okay? Did you understand everything? Some thumbs up, some anything?
Maria,
Let's see your faces.
can I ask maybe everyone who is Russian speaking if everything was clear for them? Yeah.
Yeah, thank you. Please ask, yeah.
Те, кто русскоговорящие, скажите, все ли вам было понятно? Подходит ли такой формат именно переводов в форме субтитров? Возможно ли для вас как бы усваивать таким образом информацию? Может быть, поделитесь комментариями.
Лен, ну перевод не очень, конечно, очень много ошибок в медицинских терминах, в словах.
Ну, в целом,
Я-
Лен, понятно, что как бы это не будет идеальным, да? То есть
Да,
это всё
да, да.
понятно. Вопрос как бы, можно ли усвоить, ну, как бы помогает ли это усвоить эту информацию, потому что я понимаю, что у многих английский не такой сильный, да, но в целом как бы понятно. Или нам, может быть, есть смысл какой-то организовать все-таки, ну, отдельный еще созвон с вопросами-ответами, может быть?
Ну, я понимаю, как врач, а за других не могу сказать. Я понимаю, что здесь ошибка в переводе, и я понимаю, о чем речь, но как другим не скажу. Мне показалось не очень понятно. Ну, как-то вот так.
Какие-то другие комментарии?